Hello, everyone. Welcome back to the Wednesday webinar series. I'm going to give it just one more minute to let the room fill up before we go ahead and get started. Happy Wednesday. I hope you're all having a wonderful afternoon. Thank you so much for joining us. We'll get started in just one more minute. All right. Well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on the effect of emicizumab prophylaxis on long-term self-reported physical health in persons with hemophilia A without factor VIII inhibitors in the VIII and VIII studies. My name is Alsan Murtha, and I am the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will post to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, April 8th. I am joined today by Mark Skinner. Thank you so much for taking the time to join us today. I will go ahead and turn it over to you to get started.
Well, hello all, and it's great to have the opportunity to present today on the research on the effect of emicizumab prophylaxis on long-term self-reported physical health in persons with hemophilia A without factor VIII inhibitors. This data comes from the VIII and VIII studies, which were conducted by Roche and Genentech as part of their pivotal program and are now being reported. I would like to acknowledge the contribution of Roche and Genentech for this research, as well as my co-authors, which are listed on the right side of the screen. Sorry, I'm having trouble advancing here. There we go. So here are my disclosures. There's nothing directly relevant to today's presentation. I was not funded to do this talk, nor funded for the manuscript, which I just shared. However, I have previously received consulting research revenue for other projects from Roche and Genentech. So let's begin just with a brief overview of what the study design looked like. So what you see on the right side of the screen, and this has all been previously published, and the results related to the safety and the efficacy of the VIII and IV programs have been previously published. But in brief, the study designs and the eligibility criteria for VIII and IV are part of the open-label, multi-center randomized trial that was used as part of the pivotal registration for the product. What you see here are 152 adults from VIII with severe hemophilia, congenital hemophilia with, without inhibitors, who previously were on either episodic or prophylactic treatment. And then for VIII is individuals without inhibitors. The difference between these two are the time frame for the dosing interval. VIII related to a 4-week dosing interval. VIII included the weekly and the biweekly interval, as well as for switching to those intervals along with no prophylaxis for the individuals previously studied. So this data is up through week 73, and the results here relate to 3 different instruments that I'm going to describe today. The health-related quality of life from the HemoQual study, looking at the physical health, the treatment, and the total score domains. I'll describe those in more detail. Looking at general health from the EuroQual 5-level instrument, as well as looking at the impact on work. Because this was a post-hoc analysis, there was no formal hypothesis testing, so the paper is a descriptive analysis of the results and findings from the research. So here's an overview of the participant characteristics. So among the evaluable participants, there were 176 individuals that were over the age of 18 without inhibitors. but between the two. So this is a pooled analysis for HAVEN3 and HAVEN4. I'll go into these individual metrics in detail, but at a top line, 51% of the individuals coming into this study had experienced greater than 9 bleeds in the prior 24 weeks before enrolling in the HAVEN study. 70% of the individuals had more than one target joint, and 55% versus 45% were treated episodically or on demand versus having a prior history of being treated prophylactically. The median age for study participants was 39 years old, and the annual bleed rate for the period prior to was 12.8. So let's start with first just a definition of what is health-related quality of life. So you see two definitions here, and the first comes from the World Federation of Hemophilia Treatment Guidelines, the 3rd edition that was published now about 2 years ago. And so quality of life is a concept, and it's complex. It encompasses many characteristics of an individual's life, including the social, cultural, economic, and physical effects on physical and mental health of the individual. The second definition you see here comes from the Centers for Disease Control here in the United States, and it describes the concept of health-related quality of life. The determinants of what is health-related quality of life have evolved over recent years, and the science of tracking patient-reported outcomes has certainly become a topic of greater focus in recent years as well. So health-related quality of life specifically versus quality of life generally includes an individual's perceptions about their energy level and mood, and how these correlate to the health risks, the condition, the functional status, social support, and socioeconomic status. And these are typically measured by using patient-reported outcome measures. That means the data is reported by the patient without interpretation or clarification or amendment by the individual, but this data comes directly from the patients using validated instruments to demonstrate the quality of life. So when we think about quality of life, I think all of us know that hemophilia does have a major impact. Severe hemophilia is a congenital disorder that has an impact starting early in life on overall health-related quality of life. The bleeds can lead to arthropathy and functional deficits and have a negative impact on emotional, social, and physical well-being. That prophylaxis can prevent or reduce, but bleeding events do still occur on factor VIII prophylaxis. And that health-related quality of life also reflects the treatment burden that comes with the frequent and the time-consuming infusion of whatever the treatment product is, and can have an impact on the individuals overall. And so these findings, among others, I think are well characterized, and you see a number of citations from the literature. So I won't go into those in greater detail. But let's talk about the first instrument that I want to share the results. And this is called the HemoQual, which is the Hemophilia Quality of Life Questionnaire for Adults. And this measures health-related quality of life for hemophilia. So it is a disease-specific instrument versus the next one I'm going to talk about, which is a generic public health instrument. So this questionnaire consists of 46 items in 10 domains, including physical health, feelings, views of yourself, sports and leisure, work and school, dealing with hemophilia, treatment, the future, family planning, partnership, and sexuality. And each of these is scored on a 5-point Likert scale, and there are domain scores for each domain. I'm going to talk today about 2 of these, and it's important to note that a 10-point reduction in any of these metrics signifies a clinically meaningful difference from the pre and post scores. And for a total score, it's a 7-point reduction. So here are the domains again, to sort of give you an example, and I'll drill down on these in just a little bit, but here are the domains. And so for those that haven't seen the instrument, this gives you a sampling of sort of what are the questions that are being asked of the individuals. So in the physical health, it really can relate to a variety of things, but pain is one of the components, looking at feelings about worry and anxiety, sports and leisure, and you see sort of the samples of the questionnaires that were developed with the input of individuals living with disease to see if they can reflect the attributes here. So I'm going to focus today on the physical health and the treatment, and then what the overall composite score is, because those have been identified as perhaps the most relevant where we would expect changes with the advanced treatment, and we're part of the clinical program. So what does the data tell us about a change in physical health over the course of time? So as I mentioned, HemoQual has 10 domains. Here you see the 5 questions that are included in the physical health domain. So each individual was asked to rate these at each time point using the Likert scale, so consistent across all of the domains. So for example, in the past 4 weeks, my swellings hurt, or I had pain in my joints, or it was painful for me to move. And together, these give us a composite view of what the physical health attributes are as it relates to quality of life for an individual. And so these are the results, bearing in mind that as I previously mentioned, a 10-point reduction in the physical health domain is identified as clinically meaningful. 100 is the worst health and 0 is the best health. So using the pooled data, at baseline, the quality of life mean score was 40.2, and over the course of the study period, you see there was a statistically important decline early, and that was sustained over the course of time. And so the analysis are reflected at each of the individual time points, and the cutoff for the data reporting as of week 73. Not all individuals had fully reached that, so you see a reduction from the 170 to the 118 that were fully evaluable at week 73. So looking at the same data, just a little bit different, the percentage of adults without inhibitors that scored a clinically meaningful difference. So this is looking at each individual time point and what percentage of individuals that were evaluated actually achieved a clinically meaningful difference at each study time point. And here you see that the 56% that achieved a meaningful difference at week 13 of the period. So there was an early improvement and a consistent and sustained improvement over the course of time. So I'm now going to share with you, and I'll do this consistently across the 3 instruments. There are 3 subdomains, or subgroups that I would like to talk about with each of the metrics. And these subgroups will be used in both the HemoQual and then the 2 later instruments that I'm going to talk about. And this would be looking at what was the effect of prior treatment, meaning prophylaxis or episodic treatment, the presence of target joints, and the bleeding history, having a high versus a low annual bleeding rate prior to study. And as you would expect, those that had well-controlled hemophilia or lower complications from the hemophilia prior to study entry had less room for improvement, but nevertheless, across all of the domains, and we saw improvement on whether or not they were previously on episodic or prophylaxis. But in green here, you see episodic, and those treated on demand were 43.9, and that improved to 27 over the course of the study. So individually, they had a statistically important difference, and then collectively, as I previously shared, for all patients. But regardless of whether you were treated episodically or prophylactically, there was a benefit. So for individuals that had a target joint, and it's useful to just remind everyone what the definition of a target joint is. The International Society of Thrombosis and Hemostasis does standard setting, and they have defined target joints as 3 or more spontaneous bleeds into a single joint within a consecutive 6-month period. When there have been less than 2 bleeds into a joint within that same period, the joint is no longer, within the prior year, the joint is no longer considered a target joint. This is a definition that was developed a number of years ago so that we could have a metric to use in clinical assessment and in regulatory trials. It may seem a little bit abstract for day-to-day living, but it is important to understand what the resolution of target joints is. So again, you see here in blue, those that had the presence of one or more target joints prior to treatment initiation. And you see a significant improvement over the course of time from 45.2 to 30.2, the rapid improvement, and then the consistent and constant change. For those that had no target joints, you would expect minimal room for improvement, and that data that supports the data that you see here in green. For those that had a higher bleed rate prior to study initiation, so a bleed rate of less than 9 bleeds prior to study initiation versus greater than 9 bleeds, once again, you see here those that had a worse condition were having greater bleed frequency. Upon initiation of emicizumab prophylaxis, regardless of treatment regime that was adopted, you see a consistent and meaningful improvement looking at prior bleed history. So now let's shift. We've talked about what it means for physical health. One of the other subdomains of the overall Hemoqual score is treatment. And so let's take a look at the questions, the 8 questions that make up what are in the treatment domain. So primarily these relate to the burden of treatment, what the ability of individuals, or what they feel about the injections, the burden of frequent injections, the complications, a little bit about fear and anxiety, overall satisfaction with the treatment. Because emicizumab has a different mode of delivery and affects the way treatment is administered, both in terms of frequency and route of administration, subcutaneous, it was important to look at whether the treatment regime made a difference for individuals. So again, looking at the overall treatment domain, here you see the mean with a 95% confidence interval of the treatment domain score pooled between Haven 3 and Haven 4. And there is not a specific clinically important difference that has been identified, so a specific metric. But what you do see here is that you've had a halving in terms of the treatment domain from 35.5 to 16.3. Again, a rapid and consistent reduction or improvement in the treatment burden metric. So let's put all the scores together. And so time doesn't permit, and we didn't do all of the sub-analysis for all of the other individual domains, but the total score reflects the composite of each of these 10 domains combined and weighted into a single score. So if we look at the Hemoqual results overall, the total score, as I indicated previously, a 7-point reduction in the total score is indicative of an improvement in health-related quality of life. This has been established as the meaningfully important difference threshold. And so if you look at the pooled analysis, the initial results were 33, decreasing by more than the 7 points to 22. Again, a rapid and constant decline overall in the study results. And so because this is the pool of all the domains, and changes in some of the other domains that I didn't cover would not be as significant, you don't see as big a delta between episodic and prophylactic, but you still do see reflected here for those that were previously on episodic demand that they had a clinically important reduction, and the prophylactic regime here, as you would expect, was not as substantial because the entry into the study, their health state was a little bit better. And again, we see the same data looking at target joints. So for those that had target joints, their total score improved. And for those that had bleeds, you see a 10-point or more reduction across bleeds, whether they were more or less than 9 bleeds prior to study entry. So I'd like to shift now to the second instrument. You may know it by name, you may know it by sight when I show it to you in a second, but it's called EQ5D5L. So that means the Euroqual, which is an organization in the United Kingdom. 5D stands for 5 dimension and 5L stands for 5 levels. So it's a 5-level Likert scale across 5 dimensions to assess overall quality of life. This is not a disease-specific instrument. It's used across a wide range of diseases and health conditions, and is a consistently validated instrument that is used around the world. But because it's not disease-specific, often it is thought that it misses some of the specific nuances that might relate to a disease. So here the scale is reversed. The EQ5D scale is scored from minus 0.04 to 1, or essentially 0 to 1, where a score of 1 is perfect health and 0 is death, but individuals can live in a state worse than death, which reflects the minus 0.04. A meaningfully important difference in the index score has been described as 0.07. And the second component of this, which assesses the perceived health status today, called the visual analog scale, a 7-point reduction is considered clinically significant. So let's take a look at the instrument. And so it may be familiar to you if you're not. Here are the 5 domains of the EQ5D. They look at mobility, self-care, usual activities, pain, discomfort, anxiety, and depression. And then the scoring scale on the right that reflects what the best health state that one can imagine based on what their health is today. So this is very temporal and time point specific in terms of looking at what one's results are. So here you see the top line summary of the EQ5D score for the index score, which is the overall composite score of the 5 domains, and then the visual analog scale, which was the VAS score, which was on the right side of the previous screen where you score your health status today. And so in the pooled analysis, there really were no notable changes over time. And this may well be in part to the lack of sensitivity of the instrument or the way the instrument is able to capture the relevant features of emicizumab compared to other interventions. And so in the pooled analysis, while there was a slight improvement, it didn't cross the threshold of statistical significance or improvement for either the index score or the visual analog score. And just so by reference or comparison, a 0.93 would be a typical index score for a healthy male around the age of 18 to 29, which was a little bit younger than the study population overall, which had a mean study age of 39. But you can see here just on its surface that there is an impact on health-related quality of life that is picked up compared to a general population. But the change over time while on emicizumab prophylaxis is not captured here, although there were some indications that the mobility domain, which you might expect, which would correlate to the physical health domain of Hemophilia, did have some improvement that was approaching significance, but nothing specifically crossed over. So here we look at the utility scores, again, by the 3 metrics. So looking at episodic and prophylactic treatment, there was an improvement from 0.73 to 0.8 for episodic, so just slightly below the important difference that we needed of 0.7, and then not substantial change, but consistency in terms of those that were on prophylactic treatment. Again, for target joints, so where there were no target joints, individuals start at a higher general quality of life, and that was sustained over the study period. And again, for the utility score, improvement for those that had target joints, but did not quite reach the level of significance. But nevertheless, the trend lines are in the right direction, and stability of those improvements were seen in the data. So So looking at prior bleeding history, using the same instrument, again, we see improvement, but not crossing over, and not much difference between those that had less and more than 9 bleeds in the prior study period. So now shifting to the EQ-VAS, so that's the visual analog score, where individuals scored on 0 to 100 what the best state of health that they can imagine today was. The data, a 7-point difference reflects something that is clinically meaningful change. And so between episodic and prophylactic, again, not much difference. Although an improvement was detected, it did not reach the statistical threshold, but the improvements were seen and consistent over the course of time. Similarly, for target joints, as you would expect, those that didn't have target joints started at a higher level, and that was sustained and slightly improved, as well as for those that had target joints before. And then lastly, for prior bleed history, again, not a substantial difference in terms of the history of bleeding. And what I think all of these data tell us is that in terms of general quality of life, we can expect improvements, but it doesn't necessarily mean that it's going to pass the clinically important difference threshold, but certainly the trends are in a direction that we would like to see and sustainable over the course of time. So I'd now like to talk about the third metric, which was reported in the manuscript, and that's what did we learn about the impact on missed work as a result of individuals shifting to prophylaxis with emicizumab, regardless of the treatment interval selected. So again, looking at a pooled analysis. This is not a validated question, but it's a very typical question that many of you that live with hemophilia are asked in the clinic setting or is collected routinely. But it's really looking at the 28 days prior to study initiation, so initiation of emicizumab as a part of this clinical program, versus time intervals subsequent to initiation. And so this is used to give us a barometer of what the impact on employment is. So on this slide, you see the percentage of employed adults. So this question was only asked of those that were that reported that they were employed at baseline, baseline being day 1 or the first time point prior to day 1 of initiation on emicizumab. And with emicizumab, fewer employed persons missed weeks in the 28 days than in the 28 days prior to study. So at baseline, 75% reported no missed days with a 95% confidence interval. This rapidly improved at week 13, and those improvements were seen over the course of time out to week 73, at which the data cutoff for this report was prepared. So again, looking at 3 submetrics that I've used for the other instruments, if we look at the individuals by prior treatment, you see a greater significance when looking at those that were previously treated episodically, from approximately 65% reporting no missed days to 96% after initiation of prophylactic treatment with emicizumab. The results for those on prophylaxis was relatively consistent across the study period. So the greatest impact for those that were not previously treated on prophylaxis. Again, here looking at target joints. So in blue, those that reported target joints, 1 or more, and individuals can have multiple target joints. So these could be, elbows, knees, ankles, and multiple joints. So it's not just 1, but 1 or more. We see an improvement for those that had prior target joints from 72 to 90%. And we do see improvement in those that had no target joints as well. They may not have crossed the threshold of 3 bleeds in 6 months in the same joint, but they might have had joints that would be, problem joints, but had not passed the ISTH definition. And so you could expect to see some improvements, and that's reflected on this data. And so here, again, looking at prior bleeding history. So those that had less than 9 bleeds per year, relatively consistent in the green, and for those that had a higher bleeding rate or a worse state prior to shifting to emicizumab, significant improvement between 70% and to 98% after emicizumab initiation. And so hopefully the three metrics provide some helpful consistency or overview in terms of what it can deliver. So let's talk about and put this just in a little bit of context, because while it's interesting to see a lot of data, and I've shared a lot of slides with you, it's sort of what does this all mean and how is it used? And so those that are familiar, emicizumab has been on the market now for a couple of years, first for those with inhibitors and now for non-inhibitor patients with hemophilia. But how is this data used overall or in the real world? So first, it can be important for clinical decision-making, but it can also be important for reimbursement and access. And so organizations like the National Hemophilia Foundation can use this data to help demonstrate to payers that there is an impact and value in advancing care and authorizing reimbursement for that additional care. So if we consistently can collect and timely report the well-specified outcomes using validated instruments within clinical trials, it should improve the consistency and the predictability of the technology assessments or the value assessments that payers make in deciding whether to provide coverage or make those coverage decisions. And then it should also inform the shared decision-making. And by that, I mean the discussion that an individual living with hemophilia would have with their clinician or their care team at their hemophilia treatment center, where this data could be helpful for an individual to understand the value of shifting from on-demand to prophylaxis with emicizumab, or to the potential outcomes that they could expect based on the mean pooled results from the HAVEN studies, what the impact might be on an individual's overall quality of life. And I think everyone, asks, why should I change? What would the difference be? And this helps us put granularity and a little bit of specificity in a quantified way on what the impact of a different intervention can be. And so just to focus a little bit on the market access piece, because I think all of us do worry about, is anybody going to pay for this? If it's if it's a safe drug, if it's an effective drug, if it improves my overall quality of life or has the potential to do any or all of those, is anyone going to pay for it? And so the concept of HTA, or health technology assessment, is the bridge that moves between market authorization, between the FDA, or in Europe, the EMA, licensing or approving the drug for use in the commercial market, to market access, meaning that it's going to be paid for and reimbursed. And health technology assessments go through a process of looking at, thinking about, and assigning the value. And it's more than just the efficacy and safety of the drug. Typically, health technology assessment agencies look at a range of metrics that help describe the impact, the burden of the disease, and what the impact of the intervention is on the disease. So the United States does not have a formal government body that does health technology assessments, similar to Canada, the EU, Australia, other developed countries. But there is a nonprofit independent board called ICER, the Institute for Clinical and Economic Review. And I should mention, if you didn't notice it on my disclosure slide, that I do serve on the governing board of ICER as one of the lay or patient representatives. Although I don't make individual decisions on their assessments, we do provide the governance for that. So there have been 2 prior assessments of the hemophilia treatment portfolio by ICER. There was one in 2018, and there was another one about 2 years ago. And while this quote comes from the first paper, which included individuals with inhibitors, and this was a study looking at emicizumab specifically compared to prophylaxis, I think there's an important note here, which really just underscores the importance of quality of life assessment and why we as patients spend a lot of time filling out forms and reporting data. because ICER has noted that in assessing the value, so looking at sort of the considerations for market access, that payers should be aware of the important benefits and contextual considerations that are not typically captured in cost-effectiveness analysis. And so that means all of the things that I've talked about. What does it mean on the quality of life? What does it mean on your health-related quality of life? What does it mean for the burden of treatment? What does it mean for impact on family, work, missing work? Those metrics are important and should be concluded within that. So now that this manuscript's published and the data is available, it gives us the opportunity to go back to those technology assessment agencies when they review or update their value assessments to provide data that hopefully will be given weight within their assessments, reflecting the importance of the potential for advanced therapy, and of course, the ability to differentiate with standard of care or other therapies. And so this kind of analysis and data is very similar across clinical programs. We've seen these kinds of data reported in factor trials and in gene therapy trials and other novel therapeutic trials. And hopefully, by consistently collecting it across the portfolio, we'll be able to use this data to support the market access and the clinical use and help individuals differentiate and make those decisions on what is individually important to them. So I'd just like to summarize, and then I'd be more than happy to have a discussion or any conversation about any of these elements that I've reported. So in this pooled analysis, which was an exploratory analysis based on the secondary outcomes in the clinical program for VIII and VIII, the reduction in bleeding seen with emicizumab prophylaxis in people with hemophilia A without inhibitors was accompanied by improvements in the Hemoqual A physical health score, and in those in particular that had more severe hemophilia or poorer bleed control prior to study entry, but not exclusively to them. There were benefits seen by those that were previously treated on prophylaxis as well as treated on demand. That the improvements were seen as early as the first data report, week 13, and seemed consistent or persistent up to week 73 at data cutoff. That we see that there were fewer missed days from work, and this was certainly more significant, again, with those that had poor bleed control or target joints or were previously treated on episodic treatment, making a strong argument that, that prophylaxis matters and at least further proves that point. There was no change in EQ5D5L or the Urqual results over time, but all of this does sort of reflect the importance of collecting patient-reported outcome, because it allows us to look just beyond whether a drug is safe and efficacious, but what does it mean for the individual that's living with the disease? And so this really provides sort of that 360 view of what it means to live with hemophilia or the impact of a changed treatment. Now, it is worth noting, and I don't have it here on the slide, but there are some important study limitations. So the Hemoqual instrument has been around for a long time, and although it's widely used, well-established, well-recognized, and validated, it may not pick up all of the changes in subpopulations, particularly because emicizumab is a new instrument, and this instrument is a new treatment using a new treatment modality. And the instrument Hemoqual was developed at the time that standard half-life, not extended half-life, but quite a while ago, the standard half-life with factor VIII concentrates. So whether or not it is suitable for detecting all of the change, I think is to be determined. And whether it makes a difference for those that were on routine prophylaxis or have milder phenotypes, I think is still to be determined. But nevertheless, based on what we do know about the instrument, the results are as I shared. EQ5D is frequently used by health researchers to compare between disease states, as well as to look at how the general population might be faring compared to someone living with a disease. So it provides a nice metric for benchmarking and comparison beyond hemophilia, but it often too is not able to detect differences, as was noted from this data, because it is generic and it may not reflect all of the important metrics within the 5 domains. We've also seen from recent research, which was published a few months ago, a concept called the disability paradox. And so this research suggests that people with inherited or long-term conditions, such as hemophilia, adapt to their health states, and that they may well assess their health-related quality of life better than someone in the general population that does not live with a condition. That's a great thing, because if you live with a disease, you learn to adapt, you learn to cope, you learn to thrive, but then we lose the ability to predict or to capture that using some of the generic instruments that a disease-specific instrument might do as well. So overall, although the two instruments are reliable and validated and provide important tools, they really need to be used in combination and in context for the conversation that is being had, whether it's with the FDA and EMA for market authorization, whether it's with a payer or as part of a value assessment, or whether it's when I would sit down with my clinician and make a decision. But important additional data elements that should inform the patient journey and inform clinical decision-making and help us make decisions that are informed, as well as to build the case for access. So with that, I am going to stop, and then I will stop sharing my screen, but I would be more than happy to answer any questions. My contact information is here, and so certainly feel free to reach out to me afterwards or via NHF. Thank you.
That was great. Thank you so much for sharing with us today. I do have a couple questions for you already, but I do also want to state that if anyone has any additional questions, to please use the Q&A feature on your screen. In the meantime, let me go ahead and present them to you real quickly. Okay, so our first one is that it's a statement that says, this is an amazing tool to measure QOL for hemophilia. Are there any plans to create a VWD-A QOL or an instrument to measure QOL for other bleeding disorders collectively?
That is a great question. The two instruments that were used in this clinical program are two of many. There are other instruments that are used in hemophilia, and so the clinical program, or excuse me, Roche and Genentech selected these two. And as I mentioned, the HemoQual is for hemophilia. The quality of life instruments for von Willebrand disease do exist, but they are less robust, less validated, and haven't been around as long. So there is work to do whether instruments like this or updated instruments could be effective across the full range of bleeding disorders, including those that live with rare disease. The EQ5D can be used across bleeding disorders without any hesitation, but it has the limitations that I've already noted. So there is an enormous amount of research going on. And how do we tell the story? How do we quantify the experience of living with the condition? And I expect that you will see more about this in the coming years, but these are all parts of what data are collected within ATHEN, as well as the American Thrombosis Hemostasis Network, as well as within the, within clinical programs.
Wonderful, thank you. Do you recommend that payers use these QOL tools for their decisions on whether or not to approve a future or new treatment?
Absolutely. I think that is the goal that we are, where we are looking towards, that the typical metrics for regulatory approval in the past have been the annualized bleed rate. And with modern therapies, we know that annualized bleed rates are moving very low or close to zero. So using that standard alone as a metric to compare and see the value of a new therapy leaves us all a little bit short or wanting. That we know that there are changes or improvements that come with improved or some of the newer treatment products. And so working with organizations like ICER and working with payers to tell the contextual considerations, try to quantify those so that they could be valued, really is a core part of what the National Hemophilia Foundation and others are doing, and the importance of collecting this. And so whether it's within your bleed log, you may well start to see more opportunities to provide this qualitative data so that it can be used both to track your own experience relative to others, but also to support payment decisions. We've got a ways to go for payers to fully and robustly recognize all of this, but it is important. And I'll just use one example that I often use when I talk about this, and particularly if we focus just on the annualized bleed rate. I think, again, those of us that know if you avoid risk, if you lead a very sedentary life, if you choose to lead a life where you stay on the couch and work on computer games or social media, you would likely have less risk and less bleeds than if you have a fully robust life, participate in sports and all the other activities. But you can get to zero with both of those. But the quality of life may be very different. If your goal in life is to stay on the couch and play video games, then a zero bleed rate might be great, but it may not reflect all the other things that you've given up, the worry, the anxiety, the burden of treatment. So we really need to tell the whole story, what it means to live with the disease, to get the full 360 perspective. And that's a big part of where we're trying to move the conversation.
Thank you. Another one for you. The outcomes measured showcase many benefits for Emmy. If used for other treatment options, would or could there be a downside for people with bleeding disorders?
Sorry, can you ask that question again?
Sure. So the outcomes measured showcase many benefits for Emmy. If used for other treatment options, would or could there be a downside for people with bleeding disorders?
So as we saw in this data, all of the metrics did not show an improvement. So there is the possibility that the instrument is not going to be sensitive enough to pick it up. And I suppose there is a risk of misinterpretation of the results. It really is important, as I tried to share at the end, to understand the context and some of the limitations of the instruments and interpreting them. But generally, the goal would be that regardless of whether it's gene therapy, another novel therapeutic, or looking at extended half-life versus standard half-life products, that we would see the corresponding improvements in quality of life. Maybe there would be a difference in degree. So there generally is not a downside to tracking quality of life. But we may not see sort of the same results, and that may well be due to the limitations of the instrument themselves.
Thank you. So I have one more for you. Thank you for pointing out that this worked well for severe hemophilia. Are there concerns for using this for mild or moderate hemophilia?
Yeah, again, that is a great question. I think we know, and in work that I've published independent of this, we know that mild and moderate hemophilia are not benign conditions, although the difference between someone in the general population and someone with mild hemophilia may be less, that we do see that there are impacts. And a big focus of research today is really understanding mild and moderate hemophilia, and in particular, women with bleeding disorders who more typically have a milder phenotype. What is the ability of instruments like these to pick up those improvements and changes? And so although we can see it, it may also tell us that we need some additional research to make sure that as we think about expanding eligible populations for treatment, whether we move with this therapy or others to moderate or more mild conditions to try to get closer to normal, that we're able to detect that change. So right now there isn't a specific limitation, but we're just not yet confident of what the sensitivity is to measure. And I think, as you saw, for those that started on prophylaxis had a less severe state going into the study, that the changes were less, but it didn't mean that they weren't important, and it didn't mean that they wouldn't have been important to those individuals. So more work to be done. This really is a robust and sort of rapidly evolving state of science or field of science.
Wonderful, thank you. Okay, well, I would like to thank you once again, Mark, for joining us this afternoon. We appreciate your time and expertise. I'd also like to thank every one of you viewers for joining us as well. Please note that this recorded webinar will be available on Friday, April 8th at hemophilia.org under the Events tab with all of our archive webinars. Also available in the Events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you once again for joining us this afternoon, and have a wonderful week.
Thanks all. Bye-bye.